Thank you for joining our webinar today on leveraging whole of government responses to COVID-19 for better health and well-being. My name is Robert Martin. I'm a scientist at the Alliance for Health Policy and Systems Research. Before we get started, just a few housekeeping items. This meeting will be recorded and is being streamed on Facebook. Please mute your microphones and keep your video off unless you're presenting or speaking. You can participate in plenary by writing in the chat panel or by using the raise the hand tool. We'll have some time at the end of the session saved for plenary discussion. During this time, please introduce yourself, briefly comment or ask your question, and to whom your question is directed. For now, I'd like to introduce Dr. Abdul Ghaffar, the Executive Director of the Alliance of Health Policy and Systems Research. Ghaffar, over to you.
Thank you, Robert, and good afternoon, good evening, good morning, Assalamu alaikum. I'm Director of the Alliance for Health Policy and System Research. So we are very happy to host this seminar in a series of global seminars which we are planning. And we are greatly thankful and appreciative of the leadership of the RD Amro and his team. So this, as Robert has said, it would be recorded. We will appreciate if people can keep their mics on mute and cameras off unless they are speaking. The second thing I would just want to request in the very beginning, we have a limited time and would really appreciate if people can stick to the time. I know there's a lot to say and there's a lot to share. However, it's only fair if we stick to the time required so that we can allow the participation from all the colleagues and contribute in the end. So, Robert, is Dr. Somia and Dr. Naiko already there?
Yes.
Okay, so let me formally then welcome the RD Amro. So thank you very much, RD, for your leadership. And I really want to appreciate the support and leadership of our chief scientist and the ADG Healthier Population, because this is all because of their leadership, plan, and willingness to move forward the agenda of the whole of the population and the whole of the government or the whole of the society. And we have been doing this thing over the last few years as a systems thinking, and we also had the privilege to work with the AMRO team on the whole of the government over the last 2 years. But COVID-19 has made it more relevant and more I think important, because everybody has no choice but to work as a whole of government. With these, I would like to request to RD Amro, Dr. Ahmad Al-Mandiri, for his opening remarks. Sir, over to you.
Thank you very much, my dear brother, Dr. Abdul Ghaffar, and thank you all colleagues, and we really appreciate your offer, Abdul Ghaffar, for selecting Amro to this important meeting, and we assure you all, Dr. Abdul Ghaffar, Dr. Somia, Dr. Nauk, for your support. We assure you that we are fully committed. Myself, my colleague Dr. Maha and her team, Dr. Rana and other directors as well, will be very much committed, to promote whatever sort of concept, whatever programs and work that you are planning to do for WHO and all member states in WHO. And we are really very pleased and honored to be the first sort of region, moving into that direction. So I'm really very pleased to join you, Abdul Ghaffar, Dr. Somia, Dr. Naoko, and all colleagues from the countries and all distinguished experts around the globe. I'm glad that you have selected Amro, as I said, as the region for this policy level discussion. And we assure you of our full commitment at all levels, all times, and everywhere here in the region. I very much appreciate your collaboration and support to Amro as usual. As you all know, colleagues, COVID is something that is unprecedented sort of situation, at least for the recent past history. We never had such a big pandemic, which we are facing currently. The list of challenges, this endless, when we look at it, it is a long list of challenges. It is endless list of challenges. even before COVID-19, let alone now with this COVID-19, which our countries are facing. And as you all know, 2/3 of our countries are either with chronic protracted emergencies and instability, or acute instabilities, emergencies, and conflicts, without mentioning names. However, we all witnessed some good developments in the difficult period of humanity, either here in the region or outside the region. And as we always know, in each challenge, there are tens or hundreds of opportunities. And we have many good examples, I'm sure colleagues will share. We are seeing, one of the opportunities that we have seen well utilized and more to be done in that area is the solidarity, the global and regional commitment and shared vision of building back our systems and strengthen our systems in a better manner and better mood. One key learning which is emerging from this pandemic also response is using the whole of government approach as the usual WHO advice, whole of government and whole of society, and the complement between each other, the integration and the collaboration between the two. Or as they call it, all government approach. It is probably the first time in recent history that all government entities are getting together to respond to this health crisis. And it is everywhere around the globe. WHO has historically called for bringing government ministries, different ministries, departments, and functions together for better health and well-being outcomes. And we have good examples here. Dr. Rahman and other colleagues were leading when it comes, for example, into the parliamentarians' involvement in forums and bodies. However, we are not heard that time. We have tried so many. We heard maybe in a very little mood. The reason is understandable. Whole of government is not easy to implement in most of the countries. That's why probably a response to WHO calls to use this approach have not been adequately materialized. But with this COVID-19, the situation have changed, and it is an opportunity for us to make use of it. Now, almost all governments here in the region or outside have mounted whole of government response to COVID-19. This response is not only in meeting the needs of health sector, but also addressing the socio-economic challenges which have been caused by this pandemic. And we have seen so many meetings and discussions at all levels, followed by actions and decisions taken by higher authorities in each individual country. We are seeing Ministry of Health at the center of a national response in which ministries of Interior, for example, Education, Planning, Finance, and others are contributing in a very strong manner to this sort of call. This attention to health and the Ministry of Health is unprecedented. I'm sure you share me the same idea. We are also seeing results of application of this whole of government approach in many aspects. In countries where this approach has been used more efficiently than others, we see results of more superior than other countries. Leaders from our region, including Dr. Mahar Rabbat, who is now our DG Special Envoy for IMRO, and Dr. Asad Hafiz, who is very active, while he was there in WHO, in Ministry of Health in Pakistan, representing his own country in all platforms and meetings at the global level, including WHO meetings, who are panelists today, and I'm really happy to meet them, recently published an analysis in Lancet on leadership, with some other two ministers, Dr. Saeed from Oman and Dr. Fawziya from Suman, on the importance of decisive leadership when it comes into COVID-19 response. And the wisdom, the insight they brought into that paper is really very stimulating. And this analysis emphasizes the importance of leadership, which is backed by whole government as a key to effective response to pandemic. Whole of government is working well in COVID-19 response. We are seeing results, as I said. However, we see as we move forward this time, this is the time we think of how we take these lessons forward. We should learn, document, and debate that what works and what does not work in applying whole of government approaches. That's why I am happy that Dr. Ghaffar and his team are organizing this webinar together with Dr. Naoko and IMRO colleagues, participated by key leaders in the region. I think the learnings from this experience should guide us whether we can replicate the whole of government lessons of COVID-19 response to issues which require all government approach, such as meeting the targets of healthier population of GBW13. And I'm glad that colleagues WRs, are participating. Rick Brennan, who is director of emergencies, also participating in this important meeting. Healthier population agenda is dependent not only on Ministry of Health, but also on non-health ministries and sectors of the government. How we bring them together for this common agenda, how we can create a win-win for them and us through a whole of government approach is the question that is raised. This webinar, I am hopeful, through case studies of countries from our region and discussion and inputs from experts will provide us some guidance. I will not take long time. This is just my last concluding remark. With this, I thank you all for, and assure you, as I said, that what we are discussing today will be seriously taken by IMRO and seriously implemented, and we will be monitoring that, as we say, the talk of the walk of the talk that we are having today. I assure you, Abdul Ghaffar and colleagues, on that. So I look forward to the discussion and wish you a very productive, fruitful experience in this meeting, and looking forward, to have subsequent discussions and follow-up. I'm sorry if I took a long time, and thank you very much again, Abdul Ghaffar and colleague, for bringing us into this important meeting. I wish you all the best. Thank you, Abdul Ghaffar. Over from my side. Thank you. I appreciate it.
Thank you, RD. This was very, I think, needed opening remarks. And as you said, the leadership for decision making and policy is very important, not only for emergency situation like this, but also to implement the essential health services. Now we have the chief scientist of the World Health Organization, Dr. Soumya Swaminathan, with us. She has been the deputy DG of the WHO, and before that, she was Secretary Health Research and Director General of Indian Medical Research Council in India. Dr. Soumya, would you like to say a few words as welcome remarks, opening remarks for this meeting? Over to you, Dr. Soumya.
Thank you very much. And good morning, good afternoon, good evening to everyone, and greetings, RD, Emro, and thank you so much for your opening remarks, which are very, very relevant for the topic of today. I think what in the science division, really this whole exercise is a collaboration, I think, between the science division, the Alliance for Health Policy and Systems Research, also with the Dr. Naoko's division, which is a new division that's looking at how to keep people healthy, the healthier populations, the EMRO regional office, and of course the country offices. And I think it's a good experiment. Maybe we starting with EMRO because there's a keen interest in EMRO to really think about policy, evidence to policy to action. And so we want to start with those countries that are already very seriously engaging with this. I look forward to hearing some of the case presentations from the countries today, and I think it's really good that this kind of exchange of experiences and learnings and best practices, which can benefit each other without really having to start from scratch every time. And the other point I wanted to make is that as we are trying to cope with this COVID disaster, which is an unprecedented challenge for everyone, but particularly for health systems, it's really good to think about how to apply a learning systems approach, how to continuously improve, how to learn, how to update, how to remodel our systems, adjust, and to bring in innovations, test them, document what went right, what went wrong, and then move on from there. And so building in some kind of operational research or learning will mean that governments necessarily need to work with some academics. They could be epidemiologists or clinical researchers, or they could also be behavioral and social science researchers, which are very, very important for public health applications. Particularly, very often public health programs work or don't work based on what behavioral insights have gone into designing that program. And this is something that WHO is also looking at incorporating much more systematically the behavioral insights and behavioral science inputs into the guidance documents that we make. So we've also been looking to see how WHO can do things better. We are a normative agency. We do guidelines, we do norms and standards, but we have been doing this, since the inception, since 70 years. And now in the 21st century, we need to think about how do we adapt? How do we make it better? What can we learn? Are we really using state-of-the-art techniques and technologies? And so that is what our norms and standards department is constantly trying to do, is to evolve the way in which we do norms and standards. So it's more relevant, it's more timely, it's more useful for the end users, which are, of course, in the countries, and it's also updated as the science is evolving. And that's a particular challenge we've had with COVID. Science has been moving very, very fast. Our guidance has to keep up, and you have to balance speed with scientific rigor and the weight of evidence. So that doesn't change. Guidelines still need to be based on some evidence. But at the same time, what normally would take 6 months or 9 months, now we do it in a matter of 2 to 3 weeks. So I will maybe turn it over back to you, Ghaffar, and request you to carry on with the proceedings. And it'll be very nice to see what comes out at the end, what the feedback is, and whether this could be replicated in other regions as well. And thanks again to the RD for his support and driving this agenda. Thank you.
Thank you, Dr. Somia. I think like your remarks are very enlightening, especially when you are saying this is the initiative which is between the headquarter, different departments and divisions, but also with the regional office and the country offices, but also with the policy leadership of the countries and also the research leadership. So thank you. So we are going to experiment within the organization as whole of organization ourselves. So now we'll move to our first panel discussion, and we have a very eminent group of policymakers and implementers from member countries. So the first speaker, which I would like to request, is Dr. Maha Rabat, who is former Minister of Health of Egypt and current Director General WHO Special Envoy on COVID-19 response. Dr. Maha will share with us the content and learnings from Egypt. Dr. Maha, the floor is yours, please. Over to you.
And thank you very much, Dr. Abdel Ghaffar, and thank you for Dr. Somi and Dr. Ahmed for their introductory words. I have a small presentation. Somebody going to load it? Yes, thank you very much. Okay, so I'm going to be rapidly speaking or going through Egypt's situation or Egypt's experience up till now, through the current status, the governance structures guiding the response, and the public health response, and the complementary and trade-offs and policies that are arranged around the needed emergency response and the way forward. So now, as of the 12th of July, Egypt has a total number of 82,000 confirmed cases, and we're still having like a fluctuating number of new cases every day, but seemingly they are declining, with a total recovery rate of 29.7%. Total number of deaths are 3,858, with a case fatality rate of 4.7%. And this is, next slide, please. This is the cumulative number of cases. So we're going to find that the numbers are increasing. However, there is variance in the accumulative numbers as we are moving day to day, and seemingly we are passing through like more or less a more stable phase that we hope is going to continue, particularly after easing of the lockdowns that has happened on the 28th of June. So I'll take you rapidly through the timeline, policies and actions that have been taken. So the first case was detected on February 14th, mid-February, and by mid-March, many policies and regulations and actions have been undertaken to suspend the educational facilities, announcement of the Egyptian rapid or emergency plan for the COVID prevention with the allocation of 100 billion Egyptian pounds. And then we went through different phases with different policies, supportive and coordinated actions on the government level to support public health actions. So on March 19th, there was suspension of aviation. On March 21st, closure of religious sites. And all through this, the economic impact has been mitigated in a way by different stakeholders and by different ministries in order to support the social and the economic impact. On March 26th, there was this overnight starting the curfew, which has started, and then gradually it was eased off as we were moving forward. And this is other benchmarks that I'm just displaying here. So the government of Egypt announces enhanced movement restrictions during the Eid following Ramadan, but as well what is really important is as well going hand in hand is what was happening on the public health preparation and response and what was happening in a coordinated fashion on the government part. On June 28th, the government of Egypt eased most of the restrictions, but with obligatory regulated actions on part of the communities and on part of the gatherings, like obligatory mask wearing, reverting back to the norms, but with very minimal restrictions. So governance structures, there are multiple governance structures, but what was really important is that the action was coordinated with the medical scientific community. So health was a priority and around which most of the actions have been coordinated. There were different governance structures, higher technical committee under the Minister of Health, higher COVID response committee under the Prime Minister, the Emergency Operations Center, higher committees with the university under Minister of Higher Education. So there were multiple committees. However, they were mainly regulated by a higher COVID response committee under the Prime Minister. There was this challenge between the centralized actions, policies, regulations, and the decentralized requirements on the different governance and peripheral level. So the public health response, like many of the countries, activated the public health emergency. And a positive point in Egypt was the prior experience with similar emergencies and epidemics that took place in the past years. So it was like a renewal or an activation of the emergency plans and getting it, unpacking and getting it on top with the challenges that are there with the rapid inputs and influx and the surge of the cases that are happening. Next, please. So the public health efforts have been expanded for the testing and for the tracing capacities. At the beginning, they were all under the Ministry of Health regulated support, with the central laboratories expanded to 58 peripheral laboratories, the infection and control program, testing and quarantine at the points of entry, contact tracing, and then with the surge and with the increasing number, many innovative testing ways were introduced, like the drive-through testing, and more stakeholders' resources have been introduced, like utilizing and expanding on the university hospitals' laboratories. Most of those actions were free of charge for the suspected cases and for contact tracing, for the Egyptians, foreigners, and for the refugees who have been included into the umbrella of the services provided for the COVID cases. Next, please. So this is like a tweet from Dr. Tedros thanking the President El-Sisi because the President signed a declaration that Tahya Masr, which is a donation-based national fund, will take care of the expense of the quarantine for Egyptians evacuated from abroad due to the novel coronavirus. Of course, this has changed as the epidemiological situation changed, and because of the returnees to different causes. However, this was the principle that was regulated for the quarantine of the newcomers or the incomers for the country. Next, please. So for the management and the clinical management part, there was expansion of the services starting from 50 fever and chest hospitals for triaging and 6 tertiary hospitals for isolation and treatment to 300, more than 300 hospitals all over the country, with reallocation and securing medical resources, expanding on the acute care capacities, the equipment, the garments, and repurposing of the health workforce. And this was done depending on the surge and depending on the different phases of the expansion, and as well different lines of treatment and isolation and quarantine. And with the increasing number, field hospitals were established and university hospitals were included into the framework for the clinical service provision. An issue that came out was how to provide the essential health services, and particularly to manage and to care for the vulnerable groups, particularly those with the non-communicable diseases and other diseases. And this was just added as we were moving, as the country was moving forward for the provision of those services at the different entry points and at different health facilities. And this is like a picture of one of the field hospitals. And then there was risk communication and information update as part of the public health services. Next, please. So what all through the response and the emergency response, there was the coordinated effort from the different ministries and the different governments, departments, and at certain points there were trade-offs and policies in order to mitigate the health, the economic, and the social challenges or the aspects that resulted from the different regulations and actions that have been undertaken to suppress, to contain, and to mitigate the effect of the emergency or the outbreak. So there were ramping up efforts to fight the coronavirus with allocation of money, and there was defining new models of education, fiscal and monetary policy responses to mitigate the economic impact, mitigate impact for the unorganized labor force, sector-wide support for the tourism, agriculture, for trade, repurposing of medicine and equipment production, enhancing research, stepping up interagency cooperation, and meanwhile there was continued infrastructure investments and development as the surge was moving ahead. So there were things that were moving in parallel lines, and things that were moving in coordinated fashion to support and to mitigate the results of the actions taken. So there are different challenges, of course, like any other country and many countries. However, the challenges that one would see and would find and expect because of the urgency of the requested response is sometimes the fragmentation of services or fragmentation of resources. Like, for example, fragmentation of medical services between the government, academia and the private sector, which should have come into a more coordinated framework to support and to enlarge on the services that are being provided. As well, communities as partners in the response, they should come as partners. They're responsible for decision-making, acting on the different actions and the different levels of the services. And there is always a challenge to draw the needed balance between health and the livelihood, and between public health as a priority and social and economic aspects. So it's time to rethink as well how the whole government approach will affect the 3 billion actions and as well the SDGs. And this is the time to push forward for a more coordinated way. As for the way forward, I think that Egypt now is transitioning from the crisis management to the recovery management, and the government response must accommodate the urgency, the medium, longer terms, and this will require to have like harmonizing sectors, leadership, with public health priorities, public health investment, and as well to have future expectations with a new vision and clear government strategy. Thank you very much.
Thank you, Dr. Maha. That was very helpful. And these are really the experience and the learnings and the insight you have provided to the other participants. So thanks again. Now let me turn to my colleague, friend, and an expert, Dr. Muhammad Asai, who is advisor to the Minister of Health in Islamic Republic of Iran. Dr. Asai, over to you.
Excellencies, colleagues, friends, let me first appreciate WHO headquarters and EMRO efforts for supporting member states for controlling the COVID-19. Well, let me start the first slide, if you show kindly. Can I have the first slide? Yeah. Actually, the national strategies to control COVID-19 is based on whole government, whole society. It means that engagement of the whole community and the whole other sectors. So our efforts towards control of the COVID-19 are based on community empowerment, community engagement, intersectoral collaboration, and most importantly, equity. Health for all by all. There was not any single patient that has given priority to the other one. No elderly remain without receiving really proper treatment or technologies. Well, if you look at the three graphs which I brought it here, it shows that the number of the testing has increased during last 6 weeks from 10,000 to 25,000 per day. And all these kits are produced locally because we cannot really rely on the imported kits because of the sanction. The other slides, you can see that yesterday we had the highest number of the death, 203 deaths on 13th July. Which you can reached us into more than 13,000 deaths from the beginning. And the last side, on the right side, lower one, is showing that the number of the cases which are hospitalized or treated at home. And from the time that we engage our primary healthcare facilities, I'm very happy to inform you that more than 50% of the cases are really treated at home and follow up by our primary healthcare facilities. And again, once again, here has shown that the strong Iranian primary healthcare can really help in a epidemic like pandemic like coronavirus. Can I have the next one? I brought here for you a national headquarters structure for COVID-19, which is showing that there are mainly 8 ministries are responsible for different activities and committees, and the Minister of Health, under the President, is working at the Secretariat of this national headquarters for COVID-19 management with a very regular meeting actually every two days. So for example, the Minister of Cultural Affairs is responsible for information sharing all over the country, or the Minister of Road and Urban Development is responsible for developing and dispatching the travel policies, policies and strategies, or Hajj or pilgrimage organization is supervising committee for religious organization and so on. Can I have the next one? So all the ministries, relevant ministries, are actively engaged at the national, provincial, and in district level, at the provincial and district level under the leadership of the governors. So this slide is showing our primary healthcare electronic family folder, which really assisted us a lot in screening of more than 78 million people during the first round of screening by phone from the primary healthcare facilities to the whole catchment area of each primary healthcare facilities to get information about the health of the households. And also in the second round, which was mainly focused on the at-risk group, the people who are suffering from non-communicable disease and disabled. So far, we could screen more than 40 million people. Can I have the next slide? The next slide, yeah. The national campaign is something that really is exactly based on intersectoral collaboration and community participation. The national campaign contains of 4 major activities or intervention. A care team which follow up the cases who are suspected or the contact tracing, the environmental health and sanitation team which follow up the food shops and the sanitations, the militia team at each offices and the the major ministries are really ensuring the screening of all the government officials. And also at the city entrance, we have checkpoints which measure the temperature and also refer the cases who are suspected. So among the importance of this campaign, which have been implemented in our country, we have developed different hotlines established with over 10,000 lines and to provide advice to the people. We have the online self-screening registration websites. We have recruited more than 22,000 militia, which work with our primary healthcare facility workers in order to perform those 4 major activities which I already discussed. We have established 1,000 selected comprehensive health centers, which are open 16 hours hourly or 24 hourly per day. And the major responsibility is to call the households and active case finding and screening. And in the, as I mentioned, we have managed really to finish this first round, and the second round has started with mainly focusing on the non-communicable disease patients. Launching 20,000 quarantine beds with the help of the Army, and also developing 75 guidelines and standards for environmental health with active engagement of the municipalities, universities, and Ministry of Industry. Next slide. One of the major activities that we have implemented, particularly after the New Year holidays, or before starting the New Year holidays, and it was very much effective, was a smart physical distancing. As mentioned by Dr. Rabat, and as you know, by many countries, the economic problems most of the countries are facing, even the developed countries. So we had no choice to open, but on gradual basis and step by step to see and monitor how the disease is going on. So we have launched 500 COVID-19 test units in the primary healthcare facilities. So when the people are suspected and our health, the technicians and experts are calling the families to come to the special primary healthcare facilities, we managed also to prepare the test, to get the test from them right on the spot of the primary healthcare facilities. 2.3 million small business shops and industrial units registered through a website in order to ensure the smart physical distancing. Also, the monitoring by the volunteers, by the health workers, by the public. So we engage so many volunteers in order to assist government in order to monitor the smart physical distancing. The mask application, which is an application that the people can really recognize whether they enter to the red zone or not, is very much active. and also, as I mentioned, the distancing and reopening of the economic centers step by step. However, after reopening of the second reopening phase, unfortunately, the situation become worse really. Next one. I would like to share with you some examples. Next slide, please. I would like to share with you some examples from the other sectors contributed in the COVID-19, screening and also fight against COVID. The whole government support and community engagement in production of the local personal protection equipment. Not only Ministry of Health, but Ministry of Defense and many Ministry of Industry and many other ministries, and mainly the people were actively involved in development of the local PPE. Closure of the schools and universities as performed in many other countries, but for the first time in the history of Iran, we have suspended our Iranian New Year, which was 21st March. And at the same time, for the first time in the history of the Islamic Republic of Iran, after 41 years, we have suspended the Jum'ah prayer, because we are very, very, very glad that the clergy leaders really follow the instructions by the ministries of health. Closure of the touristic and historic places, and also providing food package for the poor who really were in real need. Expansion of the health insurance and coverage of all people, that was one of the major activities that we have done. And also solidarity mega trial engagement by 30 university hospitals in 16 cities was another research activities that we were actively engaged. For your information, we have published a document which is containing all the activities related to other sectors. We call it the document for intersectoral collaboration. I personally myself, as head of the documentation committee of the Ministry of Health, interviewed more than 30 head of the ministries or organizations, and we have documented all their activities related to how, for example, Ministry of Public, municipalities, everyone is actively engaged in this COVID-19. The next slide, that is the last slide on challenges. Let me to start with sanction, which is one of the most important challenge that we are facing, not only on medical equipment, but also economic sanction has affected socio-economic status of the people, and that really has to be removed. The sustainable changes in the health and social public behavior takes time, although our TV and radio and everyone are actively engaged, but it takes time that it converts into behavior. Health and social development reform post-corona is very much important, particularly moving us towards resilience health system. We need to strengthen the emergency management as part of the health system, and particularly as part of the primary health care. Putting emergency preparedness and response management to intersectoral action at the top of the government agenda, and we need really a kind of sustainability of this emergency preparedness and response in all sectors. Post-COVID economic, social, political, and cultural technological implication is very much important, and we need, of course, the need of the countries are different from each other, but everyone definitely will face some economic and social challenges in future. To us, I think the rich countries should start from macroeconomic and then move to the microeconomic, while the poor countries, this is the households which are first suffering, and so the countries should really move towards microeconomic rather than macroeconomic. So my final word is that the WHO may encourage international economic agencies to support the poor countries. Islamic Republic of Iran is fully ready to support the other member states. And once again, we would like to appreciate WHO for its really continued support. And I would like to show my last slide to show you that not only we are providing services at the hospitals, but also our people, particularly the community health workers, are reaching the people who are very difficult to reach in the remote areas. Thank you very much, Ghaffar. Thank you very much, Ardi. Thank you very much, Sumaya.
Thank you, Dr. Sai. I think these are very important points you have highlighted. We are really like competing with the time. So I was not in a position to ask anybody else. But the next speaker, Dr. Asad Hafiz, who is Vice Chancellor of the Health Sciences Academy and the Dean of the School of Public Health there. He has been working in the policy and planning position for the last 10 years, and he is a leading scientist in Pakistan. Dr. Asad, so I think I can request you if you can stick to 5 to 7 minutes given to you. Over to you, sir.
Thank you very much, Dr. Ghaffar, and greetings from Islamabad. I'll try to stick to time. So next slide, please. So what I'll be discussing today may be a bit of background and then would focus on one government response of government of Pakistan and would touch the structure and the function briefly. Very briefly, if time permits, I'll go through the epidemic situation. Otherwise, I would straightway move on to lessons learned. So next slide, please. Right, we had our first case on 26th of February, and at that time, Ministry of Health was leading the response, and we had a number of steps taken by the ministry. However, soon it was realized that for this larger pandemic, a much greater, a multi-sectoral and a multi-level response is required, for which Prime Minister himself created a national coordination committee in which Prime Minister Imran Khan is heading that committee with all the relevant ministries, armed forces and others as member of the NCC and the chief ministers of the provinces to take decisions at policy level. However, an operational branch arm of NCC was also put in place, that is NCOC. This is the National Command and Control Center, which was established under the chair of Minister of Planning and Development and Special Initiatives, with all the relevant ministries, including health in a very lead role, provincial governments, Pakistan Army and private sector were members. Let me reiterate here that Pakistan has a very complex environment with provincial autonomy, with a number of political parties in different provinces, as well as complexities of bureaucracy and hierarchy. So it's a very interesting and unique situation. This NCOC is the nerve center of COVID response, multi-sectoral COVID response in Pakistan, which has very recently celebrated the 100th day of its functioning about last week, and it has performed very well. Next slide, please. So this is how the structure of NCOC looks like. There is the NCC and NCOC in the center, health as the lead ministry, and then we have Ministry of Information, Ministry of Interior, particularly important when it comes to implementation of NPIs, the Ministry of Transport for aviation and for railways and others, the Ministry of Education for universities and schools, Pakistan Army for coordination and implementation at district levels, other law enforcing agencies, the civil armed agencies, Ministry of Foreign Affairs, Ministry of Religious Affairs, again, a very important player, Ministry of Industries, Food Security, Climate, and special programs as cash distribution program, which is called SAS program in this country. In addition to this, the provinces, regions, we have total 7 in number, civil bureaucracy, academia, digital media, and organizations. This was the structure of, this is the structure of the NCOC, which forms the basis of this one government response for COVID. I would suggest to skip next 4 slides and let's move on to the 5th one. Next one. So these slides were showing the specific roles and responsibilities for different ministries. The Ministry of Health has, of course, the most central role about coordination, testing, disease surveillance, projections, policy guidelines, case management, capacities, and generating evidence for decision making, research, and regulations, just to name a few. In the next slide, I would give a brief example of how functioning of this multi-sectoral response was coordinated. For example, we have to buy or procure face masks or personal protection equipment for whole of the country. The process started by development of PPE guidelines by Ministry of Health, in which very specific guidelines were provided, and the projections of disease numbers for next 1 month, 2 months, and 3 months. Both of these combined resulted in forecasting, which was carried out by the experts in the ministry. These forecasted numbers were then transferred to NDMA, which is National Disaster Management Authority, again a member of NCOC, which has the overarching responsibility of procurements after receiving allocations from Ministry of Finance. Now, after procurements, both local and international, the supply and delivery to different hospitals and places again was responsibility of NDMA. And finally, the monitoring of this whole process and the use of PPE was the responsibility of core team of NCOC. So this is an example of various tasks, the interplay of different ministries at one platform in a very smooth, seamless manner, which actually took place in this COVID response. Next slide. Next slide. So this is the situation in Pakistan, and I would like to particularly point out the boxes in the lower portion, which gives specific interventions at different periods of time, and many of them are non-health interventions, NPIs, and for example, the flight coordination, the agreement with ulema, the partial lockdowns, similarly the relief packages, and the public transport SOPs and their control. All of these, though were initiated on the advice of Ministry of Health, but through the platform of NCOC, were implemented by other ministries, and then the same kind of loop was actually adjusted. So we see that from the first case, which actually was reported on 26th of February, we have now mid of July, and we are standing somewhere between 2.5 lakh cases, tested cases, and we are projecting another about 70,000 or less maybe cases in next month or so. So this projections are updated regularly based on our modeling modelers and their capacity. Next slide. So this is the epi curve, just looking a bit deeply at the pandemic situation. And for the last 2 or 3 weeks, the upper curve shows that the national figures are going down gradually. So it appears that we have passed the hump. The same is the case if we zoom into different cities and provinces. For example, this blue is Islamabad, and the black is Gilgit-Baltistan. It shows a similar kind of pattern, but this is the usual epidemiological curve. Next slide. One of the jobs of NCOC through Ministry of Health was also to consider and monitor the lab capacity and the response capacity. So this map, a GIS map, is an example of where in Pakistan the RT-PCR capacity was there. It may be interesting to watch that in February, the capacity was only in one laboratory and we could do 400 tests. Whereas end of last month, we have a capacity of 80,000 tests all over the country. And it is, if required, it can be increased with now indigenous production of the kits as well. Next slide. This is the mortality pattern. We have been able to maintain a relatively low mortality. Next slide. I'll just skip through these few slides. The deaths projections, again, so no, next one, please. So these are, the implications of COVID at the highest level was seen as three important areas. In addition to health, that is saving lives, maintaining livelihoods and salvaging economy was a simultaneous activity along with the health interventions. So our Prime Minister has been very cognizant of ensuring that livelihoods and economy is salvaged. And so all the health and other non-health interventions were actually complemented in a way so that these three objectives are obtained. So these were the overarching principles given by the NCC, and then NCOC, which is the operational wing, took these guiding principles to take various actions. Next slide. One important issue is that how do we sustain this thrust and ensure that universal health coverage and the triple billion goal and the sustainable development goals are actually and achieved in times to come through the mechanisms which have we had the good opportunity of developing through this COVID pandemic. So we are trying to get the best possible outcome of all the inputs which were done in last 4 to 6 months. So next slide is my last slide, and a few lessons learned is that the countries should have a unified, multi-sectoral and a multi-level approach with strong leadership. And as RD was mentioning, we were part of the article in Lancet last week on what leadership characteristics are required so that one government approach could be achieved. It's no small feat to have all the sectors working in union and in complementarity to each other. As was mentioned by some of my colleagues, some of legislation is also required to streamline some critical functions. And I'm talking in particular context with the complex environment of Pakistan, where we have provincial governments and the health is primarily a devolved subject. It became very obvious that weak health systems may lead to collapse of the entire sector during any epidemic or pandemic of this scale. So a continuous investment in health systems is mandatory. Ensuring that reasonable universal health coverage and further strengthening of health systems is continued with appropriate financing is one of the prerequisites for health emergencies. Addressing another very important area, the surge capacity for human resource for health. We found out that a number of our health workers actually were struck by COVID, and they are still, we are in that cycle of recovering and task shifting, which if not done very appropriately and if there is not enough capacity in the health system, may not work very well. And finally, in order to make tangible and evidence-based decisions, we must have capacity of generating evidence and using the routine information and special information for decision making, not only at the health level, but at non-health level as well. I think this is a very important point, that the quality of health information and the evidence generated by health could be used for non-health decisions or for NPIs only if the quality of that data is good and is appropriate. So I'll stop here and would thank all the organizers, Dr. Ghaffar, Excellencies, RD and others for providing me this opportunity. Thank you very much, sir.
Thank you, Dr. Asad. As I said, we are running against the time. So I think really very impressive information coming from all three panelists. I wish we had the more time. But there are a couple of things which has come across. One is the engagement of community, policymakers, and the healthcare providers. Then, I think expansion of the healthcare facilities, and then task shifting of the people and the providers in that area. So I think without delay, I would like to now give this floor for the moderation for the next panel to my friend and colleague, Dr. Arash Rashidian. And Arash, as you know, is the Director of Science, Information and Dissemination at WHO Regional Office in Amro. and he will moderate the next two sessions. Arash, good luck with the time frame. So over to you.
Many thanks, Dr. Abdul Ghaffar. Many thanks for your kind introduction. And I'm also very grateful to the Alliance and also my colleague in the Healthcare Population Department, Dr. Maha, and her team for this joint activity that is focusing on a very important issue during this pandemic. As Ghaffar said, I don't do any further introduction to the program. We are behind the timetable. So I have the pleasure to invite my colleague, Dr. Richard Brennan, who is the director of our emergency program in the region, and is probably one of the busiest people right now in the region in response to the pandemic. So, and I'm sure he has a lot to say in response to excellent presentation we heard earlier, but I really would like to ask him to limit his presentation to 5 minutes so that we can listen to other four discussants in details. Many thanks. Over to you, Richard.
Yeah, thanks very much, Arash, and thanks, Ghaffar and Sumir and colleagues. Good to be with you today. And I am conscious of the time. You know, as we've heard from the three speakers today, I think, you know, if we've learned anything from major outbreaks in recent years, I was heavily involved in the Ebola outbreak in West Africa back in 2014, and you know, the lessons from then still apply today, and going back to SARS and H1N1, you know, for any effective response to a major outbreak or indeed any major catastrophe, we need not only effective application of effective public health measures, but we need strong and flexible government leadership, and we need engaged communities. The three of them have to go together if we're going to make any progress. And I think, you know, when we're looking at some of the academic journals, there's a lot of discussion about what are the factors, what are the public health interventions that most impact disease transmission. But I think this area of whole of government approach, whole of society approach, leadership is becoming increasingly discussed and considered as absolutely vital and central to an effective response. And Dr. Hafiz referred to the paper in The Lancet last week on decisive leadership and its important role. And if you haven't read it, I would recommend that paper to you all. You know, I think in our WHO is taking this on this issue on very seriously. We had a webinar last week with the International Parliamentary Union to try and again promote greater engagement from whole of government, as well as ensure that governments were engaged and took ownership of the response. And I think as we look across the board, I mean, those countries that have been most successful in tackling the pandemic so far, and you've heard some examples from the three speakers, they're the ones that have responded rapidly. They're the ones that have demonstrated this strong ownership by the highest levels of government and established these management structures that involve not only the health ministry, but all relevant ministries and established multi-sectoral coordination. They're the countries that have secured cooperation across the political spectrum and avoided politicization of the crisis. They're also the ones that have acted on the advice of public health experts, laid out a clear vision for the response, and adapted their responses based on scientific evidence. And finally, they're the ones that have demonstrated solidarity and compassion for all population groups, especially the most vulnerable communities. And again, I think each of the speakers has touched on on these issues in different ways. I think Dr. Rabat gave a very good overview in the tough decisions that governments have to make, and some of the trade-offs they have to make when trying to control the outbreak while at the same time mitigating the economic impact and avoiding excessive social disruptions, as well as, sorry, my phone is going, and at the same time respecting civil liberties. And, we had a call with Dr. Al-Mandari and senior management here with the Minister of Health from Egypt. And it was very, it was very impressive to hear the thoughtful way that they had balanced up all these different trade-offs. And some of the decisions that were made were arguable, but they were made in the context of Egypt. And again, thinking of the broader economic, social, civil liberties type of perspective. And I think at the end of that discussion, we felt largely comfortable with the thought process and the decisions being made. I think Dr. Asai, started off by talking about how the whole of society approach has to complement the whole of government approach. And again, if we're going to have a whole of society approach, we need communities on board. We need a transparent and regular communications. We need communities to trust the decision makers and the decisions being made. And I think it was Dr. Rabat that talked about crisis communications. That's a real skill by leaders, and that has to be complemented by crisis communications is different. It's different from risk communications, and it's different from behavior change communication. But we need all of these three working in concert, and they're different skill sets. I had the pleasure to visit Iran during the early stages of the outbreak in early May. And I can affirm a number of the points that Dr. Asai made, and particularly this issue of a strong government structure at national and subnational level, as well as good representation from all sectors of society within the coordination and leadership structures. And I think that was, we came away from Iran thinking that there were key lessons to be learned. I think again, picking up on what Dr. Hafiz said, Pakistan is a complex structure, very decentralized, a federated state. And again, getting back to this point about how do you have that multi-sectoral and multi-level structure, not easy to do, but I think Pakistan has done that extremely well. And again, lessons to be learned there. So I think my 5 minutes is up, but again, I want to thank the three speakers. I think a lot of lessons to be picked out of those, and I think that they really did a tremendous job about explaining the balance and complementarity of whole of government, whole of society approaches, and using those as platforms to promote the effective public health interventions that we know work in controlling this outbreak. So thank you all.
Many thanks, Rick. So I go to the next discussant. My colleague, Gerald Rockenshaw. He is heading the WHO program in the occupied Palestinian territories. A difficult task to have in normal days, much more difficult under the COVID situation. So we are very eager to hear from you, Gerald, hopefully in a very short period of time, but reflecting on what experience you have in OPT and also in connection to the presentation we heard from the three large countries of the region. Over to you, Gerald.
Yeah, thanks very much, Arash, and thanks, colleagues, for this opportunity to also reflect a bit from the country perspective from a
Gerald, sorry to interrupt. Can you speak a bit louder, please?
Yeah, sure. Can you hear me better that way?
Absolutely, it is very well known.
Okay, yeah, thanks very much for the opportunity and to reflect a bit on the country experience from a WHO office. Now, Palestine is not necessarily a typical example to provide a country experience in the Corona crisis context. It is rather an example of a politically complex chronic crisis context that is actually characterized by 53 years of chronic occupation, compounded by a political divide between the Gaza Strip and the occupied West Bank, with no control over points of entry and massive access restrictions. Despite all these challenges, I think we saw here also the really effective whole of government approach that was put in place at the very early stages when the pandemic hit the PA and the Palestinian territory. President Abbas, early March, when we saw the first cases popping up, immediately declared a state of emergency over the OPD, and the Prime Minister's office took over the crisis management function. And that really allowed for quite some time period, actually over a period of almost 3 months, to hold the number of cases relatively stable. And to date, we still have only 72 cases in the Gaza Strip, which has a very strict approach to quarantining everybody that enters the Gaza Strip. It helped for the time being to control and mitigate any kind of community spread. Now, obviously, in the West Bank, controls are much more challenging. And unfortunately, we saw after the lifting of the restrictions and the public health measures and an exponential increase, particularly once the restrictions were lifted after the Eid period. And we are unfortunately now in the middle of a second peak, despite again having effective public health measures put in place. This is also further compounded, unfortunately, by a political development that we are seeing here over the looming annexation threat by Israel in the West Bank and the suspension of the coordination between the PA and Israel. It is impacting our response capacity, particularly in the sense of being able to import urgently required humanitarian supplies from testing kits, PPE, and intensive care unit supplies. And it is also restricting access for referral patients, particularly in the Gaza Strip. That forces the UN and WHO in a position to take over a mitigating and facilitating role to bridge this coordination gap between the Palestinian side and the Israeli side. We have been very clear that we don't want to replace or take over any of the responsibilities by local authorities, but we really do want to focus on addressing the humanitarian challenges in that context. So we're trying to work out a solution to help with the clearance of the humanitarian shipment. We do that in lockstep with our UN colleagues, with WFP, or with the logistics cluster, and we're trying to find a pragmatic solution to facilitate access for referral patients to essential health services. We do have, obviously mounting challenges in the context of increasing and then peaking case numbers at the moment. We stand with 7,734 cases across Palestine. This is a massive challenge to provide adequate testing capacity. This is a massive challenge to source PPE quantities. And it is a massive challenge to provide additional ICU equipment. We're working, as I said, not only as a one government, whole of government approach, but also in the context of the one UN approach. I would really like to emphasize that the whole UN family here in Palestine is coming together under the leadership of the UN and resident coordinator, but also under the political leadership of the special coordinator for the Middle East peace process to try to address the humanitarian challenges. I can only reiterate how essential it is to still follow this whole of government approach. I think it's more important even now to also look at a decentralized approach, to go to the provincial level, to work with local governors, to increase risk communication, to address stigmatization, which is a huge issue, and to address conspiracy theories. Unfortunately, as the DG always mentioned, it's not only a pandemic that we're facing, it's also an infodemic. Collectively and through solidarity, we hope that we'll be able to address the challenges. Thanks again for the opportunity. Happy to be part of it. Over.
And many thanks, Gerald, for excellent presentation. And also, bringing another perspective to the discussion. So we heard from Mick how he brought together the discussion of the three countries, and now from Gerald, the discussion from a country with a different situation, when the politics itself is part of the barrier in response, and how the country is trying to respond to the situation. So I'm seeing very good discussions and questions in the chat. So I'm encouraging, because we are limited in time, I'm not sure we will have a chance to approach those. So I'm encouraging everybody to, while you are listening to excellent presentation, look at the chat discussion, and also presenters might also reflect on those. So I have the pleasure now to invite my colleague to take the floor, Dr. Maha Al-Adawi. She's the director of our UHC department, Healthier Population. And she's also the co-host of this event. So with Alliance from the EMRO side, Maha is the lead person for this program. So Maha, over to you. I know you are the co-host, but I'm also asking you to kindly limit yourself to maximum 5 minutes, please. Thank you.
Thank you very much, Arash, and thank you very much to all the presenters for excellent presentations. Really, it was so good to hear the discussions, and luckily many of the points were actually covered. So let me go direct into the subject. So this is like Arash mentioned, is the Healthier Populations Division. And healthier population actually is finally that we say the WHO has put into practice what we have been preaching for a long time, that we cannot actually ensure health and well-being of the population without working together within and outside the health sector. So finally, this has been in place. However, we know this is very challenging, and I think you might hear also from some of the coming speakers, especially from Dr. Mel Williams, that it takes a long time to actually achieve a whole of government approach. It is not something easy that we can do overnight. So we have now an opportunity. We know that COVID-19 is a pandemic, it's a challenge, it comes with a lot of mortality and a lot of morbidity and a lot of stress on the health system and on the economies and the society as a whole. However, let's look at the opportunity part of it, and let's be opportunistic to take what happened with the COVID-19. The speakers, all of them actually, including Gerald and the 3 country experiences, they show that whole of government approach and actually whole of society, because we also have the community engagement, especially presented by Iran and Pakistan, is very important to tackle a problem with this size. It affected not only the health of the population, but also the economy, the society, the tourism, the religious leaders, the religious practices, everything in the society. So let's take this opportunity to make sure that we are building platforms that are happening now when we are looking at different ways of collaboration between the different entities of the countries. Because we have talked about coordination. We coordinate, we think together. We have also talked about cooperation where we can, work together, put some resources together. But this is an opportunity for collaboration, actual collaboration, when we commit all of us to one objective and all work from our sides towards achieving this objective of a healthier and much better population around us. So let's strengthen our platforms the way that we have worked, not just establish them. Let's continue to think outside our comfort zone, because if we go back to our comfort zones, I think this is going to be really we lose the opportunity of being able to move forward with a whole of government approach. So we have reached this. Now, I think from the 3 presentations, at least, it's clear that we can do it. We can work together. We can collaborate. But this will not continue if we think that this is only related to the COVID pandemic. We have to think outside. So what I'm suggesting is that it's an opportunity for us to document. Already from these presentations, we have good documentations. We heard also from Dr. Asai that they have started to document in Iran what they have been doing, how they have involved the other sectors, and how the other sectors also invited health, and the opinion of health is now being heard. So we need to document, expand on our networks. We need to look on the longer way forward of how to move from where we are now, how to strengthen this and take it to the next steps to make it sort of a more sustainable way of working together. If we are going to achieve health and well-being, if we are going to look beyond just tackling disease in the health sector, we have to think of how we ensure the collaboration of and collaborative leadership as well, not just decisive leadership, but also collaborative leadership from within and outside the health sector in order to be able to move forward. We have seen really very good examples, and I think we do have a golden opportunity, and I'll just stop here because I will not be repeating what others have been saying. This is really what we need to do to continue to have a new level of comfort zone when we can all collaborate and move forward. Thank you, Arash.
Many thanks, Maha, for excellent summary of the discussion and also the perspective that you provided. I now have the pleasure to invite my colleague and friend, Awad Mataria. So I've known Awad for 15 years as a friend, but we've been working closely together in the last 5 years. What Awad is going to talk to us about, I mean, the reflection that he's going to bring is related to his responsibility as the director of the health system department as part of the UHC cluster. From that element of the healthcare that is going to be the acting point that bring all of those together. So Awad, over to you, and unfortunately you have maximum 5 minutes, please.
Yeah, thank you very much, Araj. Again, thank you very much, colleagues, for this opportunity. I very much thank the organizers, the Alliance, and the colleagues from headquarters and from the regional office for organizing this very important and very timely webinar to discuss a hot issue related to the whole of government approach in relation to COVID. So I've been asked to reflect on the question of health systems and how health systems have been affected and looked at within this context of the pandemic. And already colleagues who have spoken before me have highlighted issues related to health system, have put some blame on the health system's performance and how health systems have been functioning and responding to the current pandemic, rightly so. But what we are trying to do now is to extract lessons from this harsh experience that all countries of the world have been going through. I would like to start by mentioning that the current pandemic has highlighted gaps in all health systems in the world, and mostly in health systems that have been looked at being the model examples for other countries to replicate, to follow, and to learn it from. So when we look at the burden of the pandemic in countries like in Western Europe, in Northern America, where countries that have been classified high on different indices related to universal health coverage or even related to global health security, we see that this is where the pandemic has hit the most. This has made us rethink our approaches for conceptualizing health systems. What are the frameworks that we have been using to model or to assess and analyze and advise reforming and transforming health systems. And I think what we are learning from this experience is that looking at how we have been looking at what we meant by health systems and the different components of health systems, we could see that there has been a lot of focus in the past on questions like efficiency in the health system. We want to make the best health outcomes from the resources that are being put in the health system. We went to the extreme that we want to have bed occupancy rates in hospitals reaching 90 and 95%. To the extent that when a crisis like COVID-19 hit the countries found themselves not having enough hospital beds to accommodate and to cope with the surge in the demand for hospital care. We have been looking at health systems being national health systems, meaning that it is a health system within the boundary of a certain country. However, the pandemic did not know borders, and it expanded and it spread itself very quickly from one country to the other within a matter of weeks, if not days, in some instances. So this again made us think now what are really the geographical boundaries of a national health system, and whether something like that would mean anything for the future. Also, something that is very much related to the topic of our today's discussion is that health systems have been very much directed toward the healthcare component. And by healthcare, I'm referring mainly to the question of curative services, with less attention to promotive and preventive interventions, which require multisectorality, which require intersectoral action and a whole of government approach in a certain sense. My final point about our previous and current look at health systems is that we have been very much linking health systems with economic development. I mean, it's great that we are presenting health as one factor of economic development, but we were also looking at health systems as an industry that is providing employment to people in a country. And we were looking about how that health system could contribute to more economic development in the future. Now, what we are proposing and what we are learning from the current pandemic is that we need really a paradigm shift, moving from these aspects of thinking about health system to questions of access and equity, how to shape a health system that would ensure and guarantee access to all needed health services to everyone, the principle of universal health coverage. We need to go from a national and a nationalistic point of view and conceptualization of a health system to a global public health approach, to a global health agenda, where all health systems of different countries would depend one over the other. And as well as we need to go into the question of intersectorality and intersectoral action to reach to the all other sectors through a whole of government approach to ensure that we are talking about health and well-being and not only about healthcare. And finally, what we are proposing in this paradigm shift is to give more attention to public health, which has not been given. I mean, looking at the main framework that we use in countries, public health does not appear in the different building blocks, sort of speaking, or control knobs, or any other framework that we have been talking about. So how to bring in social determinants of health, how to bring in the community within the health system framework and health system thinking. Now, what we are proposing is a sort of a stepwise approach of rethinking the health system, and especially about rebuilding the health system and rebuilding them better in the future. The main thing that is coming up from several people who are giving enough thinking to this question is the importance in investing in what we would like to qualify as step zero in rebuilding the health system. And that step zero is what is linked to what we call essential public health functions or the common goods for health. These are questions like surveillance, questions like regulations, questions like public health that I referred to, where not enough investment has been given there. And we feel that all countries in our region, but also globally, did not invest enough in those, and we need to give them enough attention. Once this is done, we can go to step one, which is what we usually work on, which is the foundation of the health system, building supply chains, building health workforce, building facilities to provide the services. Then we can think about step two, which is more related to the institutions that we want to build in the health system. And what we would like to think now about is how to bring in the question of health security and universal health coverage together, and how to bring in the institutions that would help us move towards health security and universal health coverage at the same time. Once those are there, we can think about the classical, or I mean, the question that many countries are interested in, and it has been raised before my intervention, the question of transformation. How to ensure the people-centeredness of the services, how to ensure public financing. But this is something that should build on the foundation of the health system and on the step zero that I mentioned. Just to conclude, I would like to mention that within our department, we are shaping the agenda of our work on health systems in the context of COVID in the future to focus on three main areas. One is to assess the response to the current pandemic and to extract the learning. And this is something that we are working closely on with Arash and his team and other colleagues. We want to give more attention to the question of resilience, and in order to ensure that our health systems are robust enough, they are able to face and cope with any eventual hazard in the future. And the third area is the question of recovery and rebuilding back better, with the focus on the essential public health functions that I mentioned, or what we call also the common goods for health. So while this is a crisis, while this has shaken our thinking and our working health system, we also would like to come out of it with an opportunity for rebuilding back better. Somebody was using the other day a term, rebuilding forward better rather than building back better. So very much, again, thank you for the opportunity and looking forward to the discussion. Thank you, Arash. Over.
Many thanks, Awad. I'm sure there is a lot more to discuss. However, I mean, we have to move to the next presenter. I have the pleasure to invite Dr. Carmen Williams. She's the manager of health determinants and policy in the government of South Australia, which has a different context to the 4 countries we heard about earlier in the discussion. So over to you, Carmen, to explain how the whole of government is contributing to the response to COVID. And you have 5 minutes maximum, please. Thank you.
Thank you very much. It's a great pleasure to be here, talking to you here from Adelaide, South Australia. I feel quite a long way away from where many of you, many of the case study presenters have come from. And of course, you've highlighted sort of that South Australia has quite a different context. What I want to talk to you about today, I think, is really highlighting what we've learnt from our experience here in South Australia, and also from working with colleagues in a range of other countries through the Global Network for Health and Our Policies, on what we understand to be the critical success factors for a health and our policies approach. Now, health and our policies is the language we use here in South Australia to describe our whole of government multi-sectorial action approaches, and but we accept that different countries use different language. So please forgive me when I use the term health and our policies. You could interpret that to be whole of government approach. So the first critical success factor, there's really 4 key ones. The first one's really about good governance for health. And I think what was really interesting and pleasing to hear from all of the speakers today, the panel respondents, as well as the case study speakers, is there was a really strong focus on governance, and that leadership and governance really sets the scene and the foundations for collaboration across agencies. It provides the enabling environment for different sectors to come together to be able to work on a common goal. I think the other area is the development of strong, sound partnerships, and that's another critical success factor. And I guess in reflecting on the case studies today, I feel that that's perhaps one area where the case studies maybe didn't have time to explore how they've gone about building those strong partnerships. Or it may be that COVID, the situation of COVID and the urgency with which COVID has hit countries, meant that actually people came together in an unusual way, and perhaps not the way that we've experienced them here in South Australia, where it's very difficult to build partnerships and you have to work quite hard and sustained in a sustained manner to kind of develop these long-term trusting relationships. But I think COVID's created an environment where people have come to the table, and perhaps where they wouldn't normally, because of the crisis and the urgency. So I think that was something that I'd like to learn a little bit more about, and I think it's an opportunity for us to be able to work out how these relationships are working in this urgent environment, and how we might be able to leverage this situation to be able to build on that and move forward as we want to address other health and wellbeing issues. I think another area, another critical success factor would be the availability of dedicated capacity and resources. And again, I think COVID-19 responses, whole of government responses, and each of the case studies have highlighted how resources have been really dedicated and thrown to address the COVID situation. And again, I think this is probably slightly different to the usual approach to working across government on health issues. You normally have to argue and hard for whole of government resources. You have to negotiate and apply really clever diplomatic conversations with colleagues to get them to share their resources to be able to address a health issue. But I think COVID has highlighted that when there is a crisis, when there is a health crisis, that we are able to kind of come together in this way and really pull our resources together. I think the fourth success factor is the use of evidence. And I think that's one of the things that's been really clear through all of the case studies, is that actually the urgent crisis situation that COVID's created for all of our countries has really has done a few things. It's highlighted the value of scientific evidence and public health evidence, and it's actually in all of the case studies, that evidence is being applied and being listened to, and is given precedence over other types of information. So I think that's a really important phenomenon. And I think and in cross-government collaboration, I think public health evidence and health evidence is often really relied on quite heavily. We have in many countries, we have access to really high quality data that other sectors perhaps don't have such able to access in the same way. So I think the case studies for me, really, there were a few things that really shone out that reinforced that this COVID situation is leveraging off the critical success factors that we've learned through health and our policies. There is a clear overarching urgent purpose. And that's one of the things we know we need if we're wanting to be working collaboratively on whole of government health issues. We need clear leadership, and that's been talked about a lot today. And I think the interesting thing is that in COVID situation, health has been looked to provide that leadership. Again, that's not always the case when we're looking to do other whole of government issues, but I think certainly in this case it is. that each of the case studies talked about a central government mandate, that they had the authorising environment from their central government, their prime minister, their lead central agency that gave health the authority to be able to do the coordinating, to be able to work towards things, and that there was a use of collaborating mechanisms. So I think they're the sorts of things that I think I could see that there were close parallels with the work that we've done here in South Australia. Just to finish off, I think COVID has provided this really special opportunity for us to be able to really apply a whole of government approaches. I think the challenge is to how, and I can see on the chat line, is how do we apply this in everyday health and wellbeing issues when the COVID situation is hopefully resolved? How do we take the lessons from the COVID experience and apply that to addressing NCDs and environmental health issues and health system issues as we move forward? And I think that might require us to rethink the role of the health system in some of those other conversations. It's clear we need to be the lead in the COVID situation, but we might not need to be the lead in some of these other areas. We might need to have, I think, one of the speakers talked about collaborative leadership. We might need to work out how we can apply that a bit more. So thank you very much for the opportunity to speak to you all today.
Many thanks, Dr. Williams, for excellent points that you highlighted. So without further delay, I hand over the microphone to my colleague, Robert. Robert, over to you, please.
Thank you, Arash, and thank you to all the speakers and moderators. I think this has been an important and interesting discussion. I see also that we have so many interesting comments and questions in the chat box, but I'm afraid where we are, we're going to need to skip straight to our Assistant Director General, Dr. Naoko Yamamoto, for our concluding insights and remarks on the way forward. So, Naoko, over to you.
Well, thank you very much. I want to say it's very enjoy this discussion and learn a lot. First of all, thank you very much the Egypt, Pakistan, Iran to share with your experiences. The country case studies is very informative, and including the final presentation with the South Australia. Thank you very much. And let me say a couple of issues I would like to highlight. First, for the COVID-19, South Australia lady said created, but the COVID-19 insisted us or guided us to come up the whole of government approach or health in all policy approach in all countries. Again, this is unknown viruses. Many new information comes up, and we all need to adapt and respond in a different situation, in a different way, together with all government, all sectors. So, and I heard that many countries has showed that the central government showed and is showing the clear leadership, but also the role sharing or partnership with local government and the society and the community. And as a health sector, we contributed, but also we need to continue to contribute by providing quality data and the information and evidence, and also keep the health system resilient. So again, this is issues about partnership, collaboration, coordination, and communication. But each country has a different situation, but we may come up with some common element which we need to succeed. And how we can continue that good collaboration, coordination after COVID-19 or even during the COVID-19, how we can create a good society or post-COVID-19. Several people mentioned about equity, how our society could make our society more equal society about it. So in the context, I would like to share with you about the UN 17 survey. This is a UNSG did the survey to ask all people to vote about the future figure of the society. More than 230,000 people from 190 member states has already joined the survey, and the responses showed us a clear picture about the time of COVID-19 and beyond. The number one vote was or is universal access to healthcare. Number two important issues for them is strengthening solidarity between people and nations. And number three is rethink the global economy against inequity and equality. So this is very encouraged for public health workers and also all workers all people who join this webinar, I believe, and how we can create such a society in a community level, local level, national level, and global level. We would like to continue to this kind of discussion. Maybe the next case study will be more data-driven and more evidence-driven case study will come. And Gaffer, I believe the Alliance will help and work together to come up with some concrete evidence and analysis about this to contribute to society. So I'm really happy to talk, continue to work with all of you about these issues. Let me say a few, only one issue in the last my comment. In our division, we are going to work with the Association Public Health Agency and academia to collect the case study about health and equity issues, especially the good practice to improve the equity in the society during this COVID-19 and beyond. So we're going to announce that activity together with our partners. So I'm looking forward to continue to work with you and discuss about this issue. Let me stop here. Thank you very much to give me this opportunity. Over to you.
Okay, thank you, ADG. Thank you, Dr. Yamamoto. We're really grateful to have you joined us today and so thankful for your thoughtful comments and reflections. On behalf of the Alliance for Health Policy and Systems Research, I'd like to thank the Regional Director, our Emerald colleagues. I'd also like to thank the Chief Scientist and again, ADG for Healthier Populations. I'd also like to thank all of the participants, all of you for joining us today, and apologies for running slightly over on time, but we're grateful for you to join us today, and we're really grateful for the comments. This concludes our webinar today. Look forward to being in touch in the future.
Thank you.